myth is PrEP is just a little blue pill. In all actuality, PrEP is so much more. PrEP, if you guys were with us from the beginning of the week, PrEP received its FDA approval back in July of 2012. Sorry, 2012. PrEP stands for pre-exposure prophylaxis and is a little different from post-exposure prophylaxis. Truvada itself is a combo medication, and so intracitabine and tenofovir is the combo medications that make up Truvada. It has been used since 2004 to treat HIV in conjunction with other medications. The other thing to really know about PrEP is that PrEP really is a gateway drug, and so oftentimes people have this, I guess, this misinformation that once you start PrEP, there's no reason for you to receive primary care, and that's just not true. And so for our young people who are engaging in PrEP, there's an opportunity for us to allow the medical providers to really build a better relationship with them in terms of the PrEP regimen and making sure that a person is on top of their baselines. It is recommended that you increase your primary care by coming in for your baseline visits. And so what that looks like is every 3 months, a person is coming in for renal function, some blood draws, HIV testing, just to make sure that their levels are great and that the PrEP is working well for them. It's also an opportunity for the medical provider to really have an in-depth conversation with the patient around, all things medical, making sure they're on top of their health interventions, their flu, their vaccines, any type of nutrition counseling that they may need, smoking cessation, weight management, and other things. It is an opportunity to really get a detailed sexual history. It is recommended for all patients who are undergoing the PrEP regimen. It is an opportunity to really overcome any discomfort that a person may have in receiving some type of medical services. Speaking of sexual risk assessment, so the CDC talks about the 5 Ps. And so anytime a medical provider is assessing a patient's risk, they want to be sure to ask questions around a person's partner. So for instance, in the past 12 months, how many partners have the patient has had sex with? So whether they're men, they're women, they're transgender, or they're both, this information is very, very important. The same is true for practices. And so when we're talking about practices, we really want to ask the patients whether they are receptive, meaning they're a bottom, or whether they're a top. These practices are necessary to really kind of have an in-depth conversation around the practices and making sure that we can offer the best services for them. It's also important for us to also identify any previous diagnosis the patient had in terms of STIs. And this is important because when we link our patients with a coordinator or a navigator around PrEP, the conversations are really detailed and they're meant to really be more conversational to make sure that the patient is getting exactly what the patient needs. You want to ask questions around condom consistency and whether the patient is using condoms at all. And finally, the pregnancy plan. So is the patient using contraception? And is pregnancy in the future something that the patient really, really wants? And so these are questions that are very, very important in terms of the assessment and making sure that you are a viable candidate for PrEP.
So I'm going to jump in with myth number 9. My name's Helen Koenig, and it's a real privilege to be able to give this webinar alongside Jermel Wallace. He's the director of our PrEP program here at Philadelphia Fight. So I'm going to jump into myth number 9. The myth is that PrEP can only be prescribed by a specialist. This is something we hear frequently. Not so much by people who are very familiar with PrEP, people at places like Fight, Mazzoni, Penn, and other places, but a little bit more in the community amongst pediatricians and primary care, family medicine providers who are maybe not affiliated with academic health centers or AIDS service organizations or public health organizations necessarily, think that because PrEP is an HIV an antiretroviral therapy that it can only be prescribed by a specialist like an infectious disease provider or HIV provider. So I really want to dispel that myth, and it's been an exciting last few months because PrEP is now a grade A recommendation by the United States Preventive Services Task Force, or USPSTF, which is a mouthful. And for those of you who are not familiar with this very important guideline making organization, this is the same organization that makes recommendations across the board to all primary care providers in the United States, pediatricians, primary care, family medicine, OBGYN, are all considered to be sort of primary care providers around things like when to start mammograms for breast cancer screening, when to start colonoscopies for colon cancer screening, when to counsel youth for obesity, when to screen kids for hearing. These are the things that primary care providers sort of live and die by. And so it's very exciting that just in the last few months, the USPSTF has officially recommended across the country that all primary care providers offer PrEP to folks at high risk of HIV acquisition. And that gets a grade A, which is the highest recommendation that the USPSTF can give. And that is because of the real depth and breadth of the data and evidence around the efficacy of PrEP. So who is at risk, according to the USPSTF? So they recommend essentially that the following groups be considered for PrEP. So we have MSM, or men who have sex with men who are sexually active and also have one of the following characteristics: either a sex partner who is living with HIV, so we call that a serodiscordant partner, or a recent STD, sexually transmitted infection or disease, with either syphilis, gonorrhea, or chlamydia. USPSTF doesn't really define recent, although other guidelines have said within the last 6 months. I think we can be sort of very loose in our interpretation of any sort of STI in the last at least 6 months to a year. And then another criteria would be if someone in this group of MSM who are sexually active also uses inconsistent condoms during either receptive or insertive anal sex, even if they haven't had a recent STD or don't have a partner who's living with HIV. Second category for whom the USPSTF recommends PrEP for is heterosexual women and men who are sexually active and have one of the following. And these are sort of similar to the MSM criteria above, but with some slight differences. So either a serodiscordant sex partner, or inconsistent use of condoms during sex with a partner of unknown HIV status or someone who is at high risk. And I think that's the tricky part here, because it's hard to know if your partner is at high risk of HIV. That's not something that we're sort of taught to assess in high school. So I think that criteria can sometimes get us a little bit into trouble. Or a person who has had a recent sexually transmitted infection with syphilis or gonorrhea. So for the heterosexual population, a recent chlamydia diagnosis is not considered to be necessarily a risk factor for considering somebody to be eligible for PrEP. Third, persons who inject drugs, who share their injection equipment, or are at risk for HIV through sexual acquisition using any of the criteria we've already mentioned above. So people who inject drugs are potentially at risk of acquiring HIV through two different ways, right? Either through their drug use or through sexual acquisition in the context of drug use. And we were very happy to see that the USPSTF did include some special sort of additional language to sort of call out the importance of specifically considering several other groups of individuals, including transgender persons, commercial sex workers, and victims of trafficking, either sex trafficking or human trafficking. There are not enough data in these groups because research hasn't really been able to enroll these groups in enough numbers to formally have an evidence-based recommendation as there are for the above categories, MSM, heterosexual men and women, and persons who inject drugs. But the USPSTF sort of recognizes that from what we know, these groups are likely at very high risk, potentially higher risk than the groups that the formal recommendations exist for, and that we should really think about them as eligible for PrEP. And finally, I just want to point out that we really need to get the word out. So despite the fact that the USPSTF has made this recommendation, a recent survey by the CDC shows that only 1 in 3 primary care providers, this is physicians and nurse practitioners, physician assistants, haven't heard about PrEP. So, you know, I think our role has always been to try and educate our peers, but also our providers and our doctors to sort of get on board with prescribing PrEP, and if they're not comfortable with prescribing PrEP, to talk to some colleagues who are and seek that education. For the clinicians who are tuned in today, I want to just talk a little bit about what you need to do before prescribing PrEP. First and foremost, the most important thing is that you need to do an HIV test on your patient, and HIV test must be negative. So of course, PrEP is for people who are HIV negative, who are trying to stay negative. If people are HIV positive, it's a different cocktail of medications. An HIV test can be a standard 4th generation HIV 1-2 test, or it can be a viral load. But the important thing about that is it needs to be done really immediately prior to starting PrEP, so within a week at most. So if someone had a recent HIV test 3 months ago, that's not good enough, because they could have seroconverted to HIV in the last 3 months, and you're saying, oh, 3 months ago they were negative, that checks the box, I'm going to start PrEP. So that's the most important thing to do prior to starting PrEP. Secondly, we do screen kidney function. We're going to talk a little bit about the safety of Truvada. Truvada is very safe and really has a very low risk of causing any problems with the kidneys. But just being extra conservative, we do screen kidney function, and the creatinine clearance needs to be at least 60 formally to use this drug on label, although we do use it every other day when off label, as providers often use medications when we have experience with it in the HIV treatment setting and know that this is safe. Hepatitis B testing. So this is important. Prior to starting PrEP, you want to screen your patient for hepatitis B. The reason for this is because Truvada actually treats hepatitis B. If your patient has hepatitis B and does not know about it, then if the patient is sort of stopping and starting PrEP for HIV prevention purposes and doesn't know that they also have, or that they have hepatitis B, the liver can get inflamed. You can actually have liver irritation and potentially liver failure from sort of stopping and starting what is also treatment for your hepatitis B of which you maybe were not aware. So knowing that a person is hepatitis B positive prior to starting PrEP is important, and you can still use PrEP to treat people who are also hepatitis B positive. You just want to make sure you're doing that in conjunction, probably at that point, with an infectious disease specialist. And finally, we're going to talk a little bit more about use of PrEP in pregnancy later, because PrEP is certainly safe in pregnancy, but we do want to get, for women of childbearing age, cisgender women of childbearing age, we do want to get a pregnancy test prior to prescribing PrEP, because it's always just important to know so that you can better inform your patient and have a little more in-depth conversation about risks and benefits of PrEP during pregnancy. Before starting PrEP, it's really important to discuss the time to effectiveness, meaning how many days do I have to take PrEP before I'm protected against HIV. And this depends by the way in which your patient would potentially be exposed to HIV. So for example, people who potentially would be exposed in the rectal compartment, these are people who are having anal sex, or who are bottoms, really need to take PrEP for what we believe is 7 days, seven daily doses before protection. For people who are potentially going to be exposed cervicovaginally, so for example, a cisgender woman who's having vaginal sex, this we think requires a little bit longer in terms of daily dosing leading up to protection. The CDC says 21 days. This is a very conservative estimate, and the WHO actually talks about a far shorter course, closer to 7 days of daily dosing prior to protection. But the most conservative estimates and recommendations would be 21 days. And 21 days are also for blood, so these are for people who would potentially be exposed through injection drug use. The reason for the difference in those days and time to protection is because of the way that the drug, specifically the tenofovir, concentrates in different tissues. So tenofovir concentrates much more highly in rectal tissue than it does in cervicovaginal tissue. And so for that reason, it does require a much shorter time to protection. Regarding the neovaginal tissue, sort of neovaginal compartment for people who have had surgery related to transitioning in terms of transgender related surgery and gender affirming surgery, we don't actually have any data there, and so it's hard for us to make any definitive conclusions about time to protection. The CDC recommends monitoring while patients are on treatment. And this is important, but it's not onerous. So we already talked about at baseline, we need an HIV test, a test of kidney function, hepatitis B testing, and a pregnancy test. At that point, we can prescribe, if everything looks good, the person's HIV negative, kidney function looks good, we can prescribe 3 months of PrEP. Every 3 months, the most important thing is that you must repeat HIV testing. And the reason for that is because if somebody is not taking their PrEP consistently and they do unfortunately acquire HIV because of that inconsistent PrEP, and then they start taking their PrEP again without getting HIV tested, then you're giving somebody who's HIV positive PrEP instead of HIV treatment, and then that person can at that point, their strain of HIV could become resistant to the Truvada, which would affect their treatment options down the line. So the HIV test every 3 months is truly critical. Other than that, monitoring again is pretty minimal. Every 6 months we monitor kidney function, and I think importantly right now, and we'll get a little bit more into this later, the CDC recommends STI screening only every 6 months, although probably we should be doing that more frequently. And when we talk about screening, we're talking about if someone doesn't have any symptoms and we're checking anyway, that's what a screening test is. But if somebody has symptoms of an STI, then we certainly would test them prior to 6 months. And then the CDC recommends lastly that at least once a year we reevaluate the need to continue PrEP. So talking about how that person's life circumstances may have changed, and whether or not PrEP is still something that they want to be part of their HIV prevention package. Personally, I think those of us who do this a lot would recommend probably talking about this much more frequently than once a year.
Myth number 8. And so the myth is adults, adolescents and young adults on PrEP should be treated the same as adults. And so that we would say is a myth because we know that our young adults and our adolescents sometimes need a little bit more support around issues related to adherence, right? And so what else can be done to support adherence among PrEP patients, especially youth? So the role of mental health is very, very important in terms of adherence. And so we want to make sure that we are linking those in need to a behavioral health specialist to be able to really talk a little bit about some social determinants that may be impacting how they navigate through the healthcare system. It's important at that age group that we link folks to behavioral health because depression and anxiety are real. And so we want to make sure that we're doing our due diligence as medical providers to support the young adults when possible. The IPREC sub-study assessed the effectiveness of anxiety and depression amongst those on PrEP, and it showed that there was a decreased adherence associated with severe depression, which is only a small portion of the MSM in transgendered women, around 1%. And then depression and anxiety alone does not seem to be the major driver of not adherence. FIGHT also conducted a study on the ACEs scale where we actually looked at depression, anxiety amongst those who had some type of childhood trauma, and there was an associated decrease in adherence on PrEP. This is the study a little bit more in context, and so overall 99 youth were sought to participate. Lost to care study.
This is a lost to care study.
In this particular study, FIGHT reached out to 99 PrEP patients who were lost to care. Of those 99 patients, 19 subjects actually completed the survey. Ironically, though, 0 experienced barriers related to stigma. And so sometimes working in the field, we often hear how stigma impacts people's ability to kind of like really navigate and stay engaged in care. And so not saying that doesn't exist, but it's really eye-opening that in this particular study, it wasn't founded. 21% remained at high risk for HIV, which is diagnosed with STIs or believe that they may have been exposed to HIV since their last PrEP visit. Out of the 99, 2 of those participants actually re-engaged to care. And so I think one of the conclusions that we found from this is that there is a difficulty in re-engaging patients once they're lost to care. And so it's really important for retention really to start at day 1. So we here at FIGHT, we have YHAP Health Center, which is a health center that sees patients 13 to 24 for all of their medical care. And we have a PrEP coordinator who's responsible for really making these connections with the youth to make sure that they're on top of their adherence plans and that there's no barriers in terms of support or adherence. But I think one of the things that we need to highlight is that we must really be innovative in our approach to how we engage youth because there's so much cyberbullying and bullying going on in the community that we really want to make sure that we are engaging them. Using social media, texting, phone calls. One of the things that we do at YHAP is aside from the 3-month follow-up, that is pretty much the standard of care, we have our retention specialists or navigators to actually reach out to the young adults or adolescent population on a monthly basis. And more so, that's to really, again, to kind of assess any issues and offer support around education. Oftentimes, people do cite that there's difficulties in coming back to the clinic because of transportation issues or not having any type of income. And so one of the things that we do over at YHAP is to make sure that each person that comes in, we give them a SEPTA card, which allows them to, one, access the visit and then give them transportation to get back as well. In addition to that, I think it's important to highlight that we also have monthly support groups, and the monthly support groups are really to engage those youth who are new to the Truvada treatment regimen, to really kind of engage with others who are also a part of that group, to really build some type of collaborative and communications around what they may be experiencing and seeing that it's not just one-sided and it's just my problem or it's just my issue or I'm the only person taking PrEP, is to really to create a cohesive unit really to kind of like really discuss have conversations about what triggers they may have or barriers they may have to completing their regimen.
So I'm going to jump into myth number 7, and I think this is a big one. And we have had questions all week at our various events through PrEP Week around this myth, so it's really important for us to include this in today's webinar. So the myth is that PrEP is not safe. And so I want to really just highlight a couple of the big concerns that we hear frequently to sort of debunk those myths. So I'll say no medication is perfect. and everything we put into our body, from aspirin or an antibiotic to a vitamin to Truvada to anything, is going to have the potential for some side effects. We always weigh those side effects against the risk of not taking that medication, which in this case would be an HIV infection. And I think that's where providers really come into play. For Truvada, Truvada is an incredibly safe and well-tolerated medication. So I want to focus on a couple of things. When we think about safety, we think about sort of side effects, which is once I start the medicine, what side effects am I going to have sort of right away, if any? And then there's sort of, is it going to have long-term effects on my body? Maybe I won't even feel them, but I may have some sort of effects on parts of my body that I won't know about, and that maybe concerns me. So I want to just talk about those two things separately. So in terms of side effects right after starting therapy, there is a phenomenon called startup syndrome that we see in PrEP. Now, you could really say that any medicine has a startup syndrome. We start people on aspirin, sometimes people have a little bit of nausea or loose stools or something like that. And so we just don't have a name for that with other medications, but it did get a name in the context of PrEP, for better or for worse. Startup syndrome is very mild and only seen in usually 1 in 5 patients. And essentially could be a little bit of a mild headache, a little bit of nausea, a little bit of gassiness, flatulence in the first day or two after starting PrEP. This can last, so it comes on usually right away, can last a couple of days, which is usual. Technically could last up to 3 or 4 weeks, although in practice we really see that rarely. It's usually a couple days. For the first 2, 3, 4, 5 days after starting PrEP, people feel some kind of way. And those symptoms pass if you continue on PrEP. Much more commonly, we get calls from people saying, I don't feel anything, I have no side effects. Are you sure PrEP is actually working if I'm taking it every day? And that's because 4 out of 5 really have no side effects, which is really just the mark of a really well-tolerated and easy to take medication. When we talk about PrEP's potential effect on the kidneys, it can affect kidneys, although it's rare. We, as you saw from the previous slide, the CDC does recommend checking kidney function twice a year, which is not very often. And the reason that it's only twice a year is because really PrEP rarely does affect the kidneys. So it's not a common thing. There really have been no reports of kidney injury in anyone under the age of 40. So when we're thinking about youth and adolescents and young adults and young people, kidney injury is really not something that should be a major concern. There have been reports of kidney irritation or a little bit of kidney injury, rarely in people over the age of 40, but this is really in folks who had other medical conditions, notably diabetes, high blood pressure, or other conditions for which they were taking other medications and had, because of those other medications, sort of an increased risk to potentially have some kidney damage when PrEP was then added to those meds. And I think really importantly, if your provider would monitor you very closely on PrEP, and if there was any sign that PrEP was irritating the kidneys, PrEP can be stopped, and any kidney injury is reversible in the context of stopping PrEP. As far as bone health, it's another thing we keep in the back of our mind, particularly for adolescents who are still laying down bone. So I think it's more of a concern for this group. You can see a very small, we usually say on the order of 1%, decrease in the bone mineral density. So that's sort of the strength, the density of your bones. This happens really early in treatment, so usually within a few weeks after starting PrEP, and then stays stable. It does not progress while you're on PrEP. And then we know that when you stop PrEP, most of the time the decrease in bone mineral density goes back to normal, and you sort of get back to your baseline level of bone health. Again, for youth and young adults who are still laying down bone, this may be more of a concern. As far as liver complications, there have never been any verified reports of anyone on PrEP experiencing liver complications, and the reason for that is because PrEP is cleared through the kidneys, not the liver. So this is something that's important because we do get a lot of questions about that. In fact, we got one on Wednesday. Another thing that comes up often with respect to safety is that people ask us if I'm taking PrEP and I'm planning on going out, drinking alcohol, maybe using recreational drugs, whatever that might be. Should I hold my PrEP? Should I stop my PrEP? Because I'm worried that if I'm taking PrEP and I'm drinking alcohol, that can be a dangerous combination either for my liver or my kidneys. Well, I think this is a really important myth to debunk, because PrEP is safe in the use in the context of also drinking alcohol or using recreational drugs. And in fact, we say it's more important to remember to take your PrEP if you're going to be drinking or using drugs, because your judgment may be affected by being under the influence of alcohol or recreational drugs regarding risky behavior. And so you really want to have that PrEP on board if you're going to be partying. And then finally, a question that does come up often is, which is why I love question and answer periods, because it wouldn't have been a question I would have predicted. But people often ask, can I become dependent on PrEP? Can my body become dependent on PrEP so that if I stop PrEP, I'll then be more at risk of acquiring HIV? Well, that is definitely something that does not happen on PrEP. So once you stop PrEP, that's of course when your risk of HIV does go up, because you've stopped PrEP, but not because your body has become dependent on it. And then we wanted to take a few minutes to just discuss whether it's possible to acquire HIV infection even in folks who are taking PrEP. So the answer to that is yes, it is possible. But most of the time, and overwhelmingly, this is in people who are prescribed PrEP but actually stop it, either because they don't think they're any longer at risk of HIV infection, or they just they lose their insurance and they think that they can no longer get PrEP because they don't have insurance, which we'll address in a later slide, because that also is a myth. Or for people who are just struggling with taking it consistently, and that any of those contexts don't have enough PrEP on board, enough medicine in their body to protect them against HIV. There have been very few cases, really a handful, that have been reported, probably a few more in real life, but really a minority of cases where people were taking their PrEP actually very consistently and still got HIV. Usually this is because they were exposed to someone with a very resistant strain of HIV that sort of overcame the PrEP, the Truvada. And so it is important to keep that in the back of our minds, that Truvada is not 100%, but if you take it every day, it's really pretty close. Really, I think the focus of this conversation should not be whether or not you can get HIV if I'm taking PrEP every day, but really supporting our patients around being able to be consistent about taking PrEP, because that is really where the risk of acquiring HIV comes into play. I'm actually going to do a second one in a row here because we had trouble staggering these. Sorry to keep talking, but I'm going to address myth number 6 as well, and then we will get back to Jermel. Myth number 6. This is a little bit of a nuanced one. So for the providers in the group or other allied health professionals, the myth is that there's no way we can sort of objectively monitor our patients' PrEP adherence. There's no lab test that can tell us if patients are taking enough PrEP to be protected. And that is a myth, because there are ways to do that. Some mostly in the research setting, but there is a way to monitor the drug levels in the urine that we've developed here at Philadelphia Fight, which is now universally available. And so we wanted to take a moment to sort of make that, talk about that. So the reason that it's important to sort of think about how we can really support our patients in as much of a high-tech and accurate way as possible around adherence is because adherence matters. Adherence is critical, and with PrEP, adherence is everything. So just looking back briefly at the studies that really put PrEP on the world stage and proved that PrEP is effective in preventing HIV in the PrEP trial, which looked at men who have sex with men and transgender women, in the Partners PrEP trial, which looked at heterosexual men and women, and in the Bangkok tenofovir trial, which looked at PrEP in people who inject drugs. And in all of those cases, PrEP was found to be efficacious. But if you look at the blue bars are in all comers. So for example, in the PrEP trial, PrEP was only 44% effective, meaning that cut your risk down by less than half of acquiring HIV. But if you look at the yellow bars, these are the people that were pulled out of each study in the analysis that were taking PrEP consistently, meaning that they had measurable levels of the medicine, the PrEP medication, tenofovir specifically, in their blood. And when you look specifically at people who were highly adherent to the medication, the efficacy of the drug was incredibly high. And this is where you start getting into these high numbers in the 90 range. And there was an additional study that showed that if you're truly taking it every single day, then your chance of your reduction in risk is almost 100%, so 99% at least, if you're taking it on a daily basis. If you look at all the studies, you can sort of stratify them on this graph to look at across the studies where people took the medication really well, like the PROUD study, all the way on the right in the green, the efficacy of the medication, the effectiveness in preventing HIV was the highest. Versus if you look on the far left with the female-only trials, like VOICE and FemPrep, where women really were not taking the medication for reasons that we won't get into in this talk unless there's a question around it, which really showed that PrEP was not effective in this population. Again, not because the medicine didn't work, but because people weren't taking the drug. I want to point out the Adolescent Trials Network, or TN110 study, because this is one of the critical studies that looked at youth. And in this study, the 110 study, we were specifically looking at young men who have sex with men aged 18 to 22. And this broke out adherence by essentially race and ethnicity. And you can see sort of overall in the red bar, well, actually, let me point out, so this black dotted line is essentially the level that would need to be maintained to be protected against HIV in the rectal compartment, which we know, and we can talk a little more about this later, is at 4 or more doses a week. So 7 days a week is best, but 4 or more if you're potentially going to be exposed through anal sex, it is almost as good as 7 days a week. So that dotted line is essentially the levels that would keep you protected against HIV. Excuse me. And you can see over a 48-week period, so almost a year, the levels that were monitored in the blood of different races and ethnicities broken out. And so even in red, so that's all comers lumped into one, once you sort of get past week 12, nobody was protected against HIV. So the level fell below that black dotted line. I think one of the most concerning outcomes of this study is that if you look at the green line, which is Black and African American men who have sex with men, youth, this group at no time during the 48-week period of the study was protected against HIV. And so if one of these young men had come into contact with someone who was HIV positive, despite the fact that they were prescribed PrEP and on the study, they were not taking the medication consistently enough at any point throughout the trial to be actually protected against HIV. And so because of that, Philadelphia Fight, in conjunction with the Children's Hospital of Philadelphia and the University of Penn, developed a urine test. This was several years ago, but it's been studied over the last few years. Results have been presented widely, and it's been shown to be very effective in helping providers monitor our patients' adherence to Truvada so that we can identify early that patients are struggling with adherence, and we can have an objective way to sort of jump in and say, hey, you might need some extra support, or let's have a more real conversation about some of the barriers that you may be experiencing. This is a slide from YourSure, that's a diagnostics company, and YourSure has really been able to take this test that was developed by Fight Penn CHOP and essentially bring this to market and make it widely accessible from a public health perspective, reimbursable by insurance companies, and easily orderable by clinicians across the country. And we can certainly take questions about how to incorporate this into your practice at the end of the talk if that's of interest. But essentially, the concept is very simple, and just like for many other medicines that we use, cholesterol medicines, diabetes medicines, etc. Essentially, when a patient comes in, they give you a urine sample, which we should be doing anyway to monitor for STDs in this population. Urine sample gets sent off to a lab where the level of tenofovir is measured, and that level comes the result of that level comes back to the provider, who then essentially is able to have much better information on which to counsel their patients around adherence to PrEP. We piloted the use of this test at YHEP, our youth agency at Philadelphia Fight, several years ago, and found that in contrast to that ATN study that you saw, where at no time during a 48-week period were young MSM of color protected against HIV, when using this urine tenofovir test during a 48-week period, throughout the entire study, we were able to keep over 70% of these folks, this was 50 young MSM and trans women of color, protected against HIV because they had measurable drug levels. And this is because when they got a drug level back, we fed that result back to them and said, hey, you're not taking this medication well enough to be protected. What can we do to support you around improving your adherence? So what this has led to at Philadelphia Fight is a really a frame shift in the way that we are able to offer care to our patients around PrEP. And so previously, the standard of care had essentially been, we see our patients 4 times a year, we talk to them about adherence, they tell us they're taking the medicine, we may spend time with them talking about adherence, or maybe in a busy provider practice, there's not much time to talk about that. And essentially, there's a sort of one-size-fits-all model. The model that we've moved toward and that we encourage others to move toward is targeted PrEP adherence support with an actual objective piece of information. So that changes this model to be as follows. You still have your quarterly or more PrEP visit. You do everything that you would do, talk to the patient about their adherence, barriers, etc., and then also check tenofovir level. If that level comes back showing that the person's taking their medicine, they would continue down the path that they're on. But if it doesn't, if it's incongruent with or discordant with or differs from what they've told you in that visit, that is a real opportunity before somebody becomes HIV positive just to weigh in and really wrap our arms around that patient and offer them a number of resources that may help them with adherence. This could be a case manager. This could be a long-acting injectable medication when, if and likely when these medications become available. Injectables are not yet available, but probably coming soon. Do we just need to see them more frequently? Can we offer them smart pill bottles that remind them to take medications? Or do we just need the provider or the staff or the PrEP retention coordinator to just have a little bit more of a targeted, sort of personalized counseling session with the patient?
This brings us to myth number 5. Myth number 5, PrEP can only be taken as a deli medication. And so we want to debunk that myth, primarily because we understand that we have to meet people and patients where they are. And so because of that, we have this, we call it vacation PrEP or event-driven PrEP, right? And it's this whole thing where patients can take their deli medication while on vacation and for 1 week before and after their trip. And so we know that our patient population may decide to go to, let's say, the Bahamas, and they meet a nice Caribbean man, and they know they're going to have a little fun while they're on the beach. And so how it works is that they would take 2 tablets of Truvada 2 to 24 hours before sex, 1 tablet of Truvada 24 hours later, and then an additional tablet 48 hours after they took their first pill. And so the IPREGAY trial provided the first evidence around this event-driven PrEP regimen. And it was really kind of like designed to be taken on an as-needed basis. And so you see the nice little pictures we have here that represent when, in fact, the patient needs to take the medication. So all in all, you'll take 4 medications of Truvada, taken over 3 days to cover 1 sexual encounter. And so some folks may think that this is a bit too much for them. And so when we are talking to our young adult population, this may be a little bit too much for them. And so taking deli PrEP may work. And so PrEP is not a one-size-fits-all. It's really based upon your own sexual behavior, your own sexual practices, and what works best for you. Kind of going back to what Dr. Koenig said earlier, around your shore and testing the adherence of PrEP in your system, it's important that when we are engaging in conversations around your shore, we don't want to use it as a policing tool, because we know that some of the youth may engage in sex-driven PrEP. And so we're very aware of that. And so it's really targeted counseling to kind of get to the bottom of how PrEP is working best for the target population.
And
Oops, I'm sorry.
Jermel, do you mind? I just want to make a point real quick on this. So I think that was very well said. Two important points. One, the eProgate trial was done in men who have sex with men and specifically relates to rectal exposure. So on-demand PrEP or sex-driven PrEP is not an evidence-based option for women or for people who could be exposed through the cervical-vaginal compartment. So that's one important thing. And then the second thing is just for the providers that are tuned in, this is something I talk about with every patient right at the beginning when I start them on PrEP, even if they are choosing to do daily PrEP. And the reason for that is because sometimes people kind of take sex-driven PrEP into their own hands, and they've heard the concept, and so even though they start daily, they may decide down the line, you know what, I'm just going to take it around the time of sex, but they might not know to follow this exact schema that Jermel has laid out, and maybe they just pop a pill before they go have sex or pop one after, and we don't really have evidence around taking on-demand PrEP in that way, any other way than in this, the way that's laid out in the picture. So I talk about it at the very first visit to say, hey, if you choose to switch to on-demand PrEP from daily, which is something that is evidence-based and is starting to appear in guidelines in the United States, and certainly is an option that's recognized as a standard of care in places like France and Western Europe. If you're going to switch from a daily to an on-demand schedule, call me or let's talk about it, or this is the way to do it. Don't just take a pill before or after sex.
Thank you. Decisions to stop and start PrEP should really ideally be discussed with the provider, as Dr. Koenig said. On PrEP discontinuation for any reason, you have to document the following. You must document the HIV status at the time of discontinuation, and that's important. So one, make sure that you're having a true conversation about status. And then the reason for the discontinuation. And so I think that's important because as we're always trying to reach back into the community to get people re-engaged into care, it's important to really understand when we're going back to them to understand what prompted them to discontinue their treatment altogether. And then thirdly, any recent medication adherence and reported sexual behavior must be documented. And we want to make sure that's documented because if we are attempting to restart, we want to make sure that the PrEP that we are prescribing can work best for you. When a patient wishes to resume taking PrEP after they have stopped, we want to make sure that they consult with a medical provider and repeat all the prescription evaluations, making sure, most importantly, that they had the HIV test, and then engage the patient in a conversation really around what prompted them to stop, what prompted them to start, and the commitment to continue using PrEP as prescribed. Because as Dr. Koenig mentioned earlier too, people have these PrEP bottles that they had once before and just decide that they want to take it when they want to take it. And I think part of that is a little dangerous because you can build up resistance if you did seroconvert during that time and you were not taking the medication. So it's really important to always consult with a medical provider and talk with your retention specialist as well. Cool.
So myth number 4, this is another big one. PrEP increases the rate of STDs, or sexually transmitted infections, STIs. So as many people know who are tuning in from the Philadelphia area, we do have an STI epidemic in Philadelphia. We have rising rates of sexually transmitted infections, specifically and most notably syphilis, although I think most gonorrhea, chlamydia are also on the rise as well. And so question commonly comes up, well, you know, PrEP was approved in 2012 and we're seeing this rise in STDs across Philadelphia and across the country. this must be because of PrEP. And if I, as a provider, prescribe my patient PrEP, am I going to be contributing to higher STD rates? Is my patient going to have riskier behavior? And this is a myth that we would like to debunk. So the rate of STDs is high among PrEP users in real world settings. So we're not saying that STIs are not an issue and need to be screened for, but we're specifically trying to debunk the idea that if we start PrEP on somebody, that immediately their behavior will change and they will have many more STDs. If we look back at the iPrEP study, that study found no evidence of increased risk behaviors, meaning people are having more partners, that they're using fewer condoms, that they're having sex with more partners who have STDs, etc. And in fact, what has been postulated, and I think what we've seen in practice, is that when you engage people who are not otherwise going to be engaging regularly with the medical community, that you're going to be able to offer more frequent counseling and testing around HIV, counseling and testing around, counseling and education around condom use when it fits into somebody's plan for themselves and their sexual relationships. More conversations and screening for STIs, because STIs can frequently be asymptomatic, that means no symptoms. That sort of bringing folks who are not necessarily engaging with healthcare, they're not seeing a primary care doctor, into a little bit more to the healthcare field, actually may make sexual practices safer in the long term. And so for some people, they may have more riskier sex after starting PrEP. For other people, their risk may go down. And so on average, there's not been shown to have a negative effect on more STDs overall and after starting PrEP. The other thing that we know is that because people who are taking PrEP, and anyone who's at risk of HIV, whether or not they're taking PrEP, also are at risk of other STIs, we know that we're really reaching those at highest risk when we see people on PrEP sort of coming up with STIs, getting STIs. We know, okay, that's gonorrhea, that's syphilis, that's chlamydia. I can treat that person for that, but at least they're not going to get HIV because that's something that I cannot cure. So just in the worst case scenario, let's think for 1 second about what if patients do start developing riskier behaviors after starting PrEP? And I think this is a really interesting question because the answer to that question is really not known. But there was one really interesting study by Janice et al. That was a modeling study. So they said, hey, what if people decrease their condom use after starting PrEP? What if that decrease was 40% decrease? So almost half of the time they didn't use condoms when they would have before. Actually, still more STDs would have been prevented than if people had not started taking PrEP, both gonorrhea and chlamydia. Even if you decrease condom use 80%, so this is like getting rid of almost all condom use after starting PrEP, we would still have lower rates of STDs relative to not starting PrEP. And what is the reason for that? So even if people are not using condoms, which is not something we say, we don't advocate, we don't sort of counsel our patients, when you start PrEP, you don't have to use condoms. We talk about this in a sort of, as a colleague of mine likes to say, both and approach. PrEP will prevent you from getting HIV, but it won't prevent you from, a pregnancy, from another STI. So there is a role for condoms, but if condoms are not in your repertoire, then you can still use PrEP and that will prevent you from getting HIV. But the reason for seeing a decline in STD rates, even if people do stop using condoms, is because we're seeing these people more often in the clinic, we're screening them more often for STDs, we're treating those, and we're therefore preventing them from passing those on to other people without knowing it. Because again, many times we have an STD, we don't know it because it doesn't cause any symptoms and we can then pass it on. So by seeing people more often while they're on PrEP, screening them more often and treating them, preventing transmission to others, overall STI rates are modeled to go down even if people's behaviors change. And we don't even know that people's behaviors do definitively change after starting PrEP. How often should we be screening for STIs in people taking PrEP? This is a great question. As we mentioned or described above, the CDC's recommendation is once every 6 months. But there have been several abstracts and now papers actually showing that this is not enough. And so one study out of San Francisco showed that if we only follow the CDC recommendations, current recommendations, and screened every 6 months, we would be delaying treatment for at least 35% of sexually transmitted infections. And that screening every 3 months instead of every 6 months prevented 3 sex partners per case of a sexually transmitted infection from being exposed. And finally, in that study, they showed that 150 gonorrhea infections and 159 chlamydia infections would have been missed if throat and rectal screening had not been conducted. So this is critically important because on PrEP we recommend, and for anybody who's at risk of a sexually transmitted infection, we recommend triple screening. So triple screening means that we're collecting a urine sample to screen for gonorrhea, chlamydia. We're doing a swab of the back of the throat and a swab of the rectum in people who are bottoms to look for gonorrhea and chlamydia in those areas so that we can identify any asymptomatic infections and treat them. Many providers are not doing triple screening and they're only screening for STIs in the urine. But this will miss, as you can see, almost all of the gonorrhea and chlamydia infections. So I think it's a really critical point. Finally, there was a study out of New York City conducted at a very large LGBT health organization in New York City called Spark. And they also showed that if STI screening was only done according to the current CDC guidelines every 6 months, that would have delayed diagnosis and treatment for 24% of PrEP patients, meaning that 40 cases of rectal STDs and 3 cases of syphilis would have been missed, and treatment would have been delayed. And every time there's a delay in treatment of an STI, there's a risk of passing that STI on to other partners. So just before we jump into myth 3, we at FIGHT screen our patients for STIs every 3 months, and more frequently if we have concerns about new partners or behaviors that could put people at risk for getting STIs even at shorter intervals than every 3 months.
Myth number 3. So PrEP is only for men. So we want to debunk that myth because PrEP really is for anybody who's at risk for HIV and want to protect themselves. And so when we look at this this chart here, we see that women account for 19% of new diagnoses in 2015. And then we also see that in injection drug use is around 14%. There has been an increase in HIV amongst Black and Latina Hispanic women. They have been disproportionately impacted by HIV. And so this begs the case why it's important for other populations outside of men, cis men, to be offered PrEP services. To take it a step further, so looking at pregnancy, breastfeeding, and contraception, PrEP is safe and effective for women who are at substantial risk for HIV acquisition. So when we're thinking about what happens during conception and pregnancy and during the postpartum period, we know that PrEP is safe and effective during those time periods. Long-term safety of infant exposure during PrEP and breastfeeding has not been determined. There may be some concern around breastfeeding when women are taking PrEP and what that may do to the baby. But overall, taking PrEP for women who are childbearing are safe. PrEP does not reduce any effectiveness on oral contraception, so that should be noted as well. And then another important question. So oftentimes, you know, when someone is childbearing and they go in to deliver, they are giving a HIV test, at the beginning, within their first trimester, and then again when they're delivering. But
if they're at high risk.
If they're high risk, right. Any other subsequent visits, they're not really being screened for HIV. And so if someone is engaging in sexual behaviors and their partners may be infected with HIV, it's possible for transmission to happen. And so it's important that we increase our screening of those who are pregnant from not only between the first trimester and when birth happens, but subsequently in between. If a woman acquires HIV during pregnancy, there is significant risk of passing HIV on to the baby. So again, routine screening in male patients or male partners of pregnant women can afford women the chance to, one, get on PrEP and then avoid infection for themselves and then passing it on from mother to child.
Yeah, and I think the reason that we included this slide, it's not something that we actually talk about very often, but as Jermel mentioned, it's routine, guideline recommended practice to screen all women in their first trimester of pregnancy for HIV. The guidelines suggest that you don't need to repeat screen unless somebody's at high risk during the rest of their pregnancy. But I think the question that we wanted to raise for you today is, what about their male partners? Nowhere in the guidelines and nowhere in practice do OB physicians, clinicians reach out and screen male partners of women who are pregnant. And so the concern is, from our perspective, maybe we should rethink that, because now that we have a medication like PrEP, having a negative HIV test in a pregnant woman in their first trimester doesn't mean, as Jermel said, that you can't then subsequently contract or acquire HIV. And so if we screen a male partner and we find that they're positive as part of routine obstetric practice, then that really is an opportunity to then put that woman on PrEP.
And then when we look at HIV and transgender women, we know that there is increased need for trans-identified women to take PrEP. So when we look at the HIV prevalence, we're looking at 49% higher the rate of HIV in women than the general population. And so that's mind-boggling statistics. And so why wouldn't we encourage trans-identified women to kind of start the PrEP regimen? A lot of questions arise often when trans-identified women are considering PrEP. They want to know whether or not the tenofovir or the PrEP is going to really have adverse effects on estrogen or testosterone levels. And so there's no immediate impact on the actual hormone itself. However, on the flip side, the hormones may decrease the tenofovir levels just slightly, but there's no significant clinical data to kind of like support, so I think it's still ongoing. But that wouldn't be a reason for trans women to not want to take PrEP. And so I think it's important to make sure we're highlighting that when we come into contact or engage in communities around PrEP intake.
Myth number 2, getting to the end. This is an important one because, as Jermel pointed out earlier, sometimes people become lost to care because they think if they lose their insurance, they're no longer able to take PrEP. Or even earlier than that, people never come into care because they think, I don't have insurance, I can't get PrEP. So this is not true, and we really want to debunk this myth today. PrEP is accessible to everyone through a variety of different ways. So how do you pay for PrEP? So if you do have health insurance, PrEP is covered by most insurance providers. And by most, I really think it's every insurance provider that we've come into contact with. For people who have had medications, paid through their health insurance, sometimes there's a copay, sometimes that copay is low, sometimes that copay is really high. Some health insurance plans have really high deductibles that have to get paid down prior to the medications being covered. And so to counteract this or to support our patients around this, there's a copay assistance card from the manufacturer of Truvada, which is Gilead, that covers up to $7,200 a year with no monthly limit. So this copay card is something that the pharmacists can sort of tack on. These can come usually from the pharmacies, although some clinics are able to, are knowledgeable of these as well, around these as well. But essentially this number on the copay card sort of gets added onto your health insurance number. And so whatever your copay or deductible is, you can, again, have $7,200 worth of assistance to cover those costs per year. Patients without insurance, people who are uninsured, may be eligible for the Advancing Access Program. This is a program also through the manufacturer of Truvada that essentially collects information around your income and ability to pay for the medication. And for people without health insurance, this is the most common way that we've been able to very successfully obtain fully covered free medication for our uninsured patients when it comes to PrEP. There are some sort of tricky areas. One of those is people who are enrolled in government healthcare programs. So for example, Medicaid, Medicare, if there are some copays, if they're in the sort of feared donut hole of Medicare, sometimes these folks are in a funny, we're in a bind because people who receive, who are insured through government healthcare programs like Medicaid and Medicare can't access the copay assistance cards if they do have higher copays than they can afford. And so in these situations, most of the time the copay is very, very low for folks on Medicaid, on the order of a couple of dollars. But for folks who can't afford those copays or in situations where the copays can be a little bit higher, it's important to be accessing PrEP in a place where the staff know how to get around these situations and where the loopholes are, because there are independent copay assistance foundations that can be applied to that can cover copays in these situations. So if you're in a place that knows a lot around about prescribing PrEP, if the staff is knowledgeable and they're used to prescribing PrEP, this medicine should be able to be obtained at low or no cost for anybody who wants to start it, regardless of circumstance. So if you're struggling in your provider setting and you're told that PrEP is not covered or that there's no way for you to pay for the medication, you're falling into one of these loopholes, we encourage you to ask your provider to reach out to Philadelphia Fight or another organization that can maybe assist them to help your patients get the medication they're looking for.
Drum roll, please. Myth number one, it's difficult to get started on PrEP in Philly. And so I think I will say that there has been concern around access. I do think that's it's very real. However, I think here in Philly, it's particularly Philadelphia Fight, it's actually much more easy to get PrEP related care. And so if you look at this map right here, this is all the dots around Philly of providers that offer PrEP services. There's also the Philadelphia PrEP Health Information Line at 215-985-2437. That is a number that you can call to be able to identify those in the area that offer PrEP-related care. And then us here at Philadelphia Fight, we have a PrEP hotline, 215-545-PrEP. And you can call that number to get information or be connected to a PrEP retention coordinator who can answer questions for those interested in starting PrEP or have questions around how to get into care or make an appointment. There's also prep@fight.org, which is our online portal. Anyone can send a message to that portal, and the hope is that someone gets back to you within a few hours. You can leave questions. That those emails are confidential and it's not able to be shared with anyone. We're excited that we also have an Instagram page now where you can connect with us and find us out in the community. Instagram @prep_on-the-go. And then, there's one more slide. And then we're also happy to introduce, within the next few weeks, we should be rolling out our Go PrEP program. And our Go PrEP program is an opportunity for those interested in starting PrEP or have information or have questions around how to go about getting an appointment. You can actually talk to a prevention PrEP coordinator using these ways to connect. So it's iMessage, Skype, Facebook, FaceTime, and then you can also email and also use the 215 PrEP number as well. And the idea here is that you will be connected to these people via the video. Oh, here we go. Here's the schematic. And so this is the workflow of it. So interested individuals will then connect with us through email, phone, hotline, or website. Like, be connected to the PrEP coordinator via any of their means that was selected. The PrEP coordinator would then schedule a video to chat during any time of day or night. Verbal consent is obtained, and then the call through Go PrEP happens. On the call, education is provided about PrEP. You discuss the benefits on PrEP to see if you are even a viable candidate, assess your insurance status, answer any questions. And then those who meet the criteria and able to kind of start the PrEP regimen will then be advised to come in through a visit and be seen with a medical provider. That's the first iteration of Go PrEP. More big things to come. And then lastly, this is a snapshot of our team. We have Mr. Jason Culler, who is our PrEP retention coordinator at John Bell Health Center. To your immediate far right, we have Harlan Shaw, who is our PrEP retention coordinator over at our YHEP facility. And at the bottom, we have Lyndon
Lally Teresco.
I was going to mess it up, so I didn't want to say it. She is our research guru here at FIGHT and all things PrEP research. Dr. Helen Koenig, who is next to her. And then at the top, we have our PrEP consultant, which is Devin Clark. And then myself, yours truly, Jermel Wallace, the director for the PrEP program. This has been a joy to kind of share this information with you, and we'll see what questions we have next.
Thank you so much, Dr. Koenig and Jermel. This presentation was very informative, so much so that we have several questions specific to everything you just covered. So I'm going to ask them now. You have two questions specific to the insurance coverage that you just spoke of. One question was, does Medicaid pay for labs for PrEP?
I can take that question. Great question. Yes, Medicaid pays for the labs for PrEP. So any insurance provider, insurer, Medicaid, Medicare, commercial insurance should pay for the labs for PrEP. And the reason for that is because they're not anything sort of fancy. They're really basic labs: kidney function, STD screening, and HIV hepatitis B testing.
Okay. There's another question specific to that as well. If a person is uninsured and interested in PrEP, are there resources out there that you are aware of to assist them with getting labs done at a lower cost or no cost? We have found at our agency that there have been times that the lab cost every 3 months can be costly or cost more than the client makes and is willing to pay.
Yeah, so that's a good question. I think this is coming from maybe a provider. So if a patient is taking PrEP and they are being seen at a practice, and their sort of medication and labs are generally covered by their insurance, then there shouldn't really be an issue because those labs are covered by insurance. Every once in a while, insurance company won't cover labs. It's very rare. And I think also people are maybe asking about patients who are uninsured, who can access free medication through the Advancing Access program, but that doesn't, the Gilead Advancing Access program does not cover lab tests. So here you can give the medication. This is certainly the case at a place like Penn, where I also work, where we can certainly access the medication for free, but there's no way for an uninsured patient to have their labs covered if they don't have insurance. And so I think the question is around, are there ways for people to get sort of lower cost labs? Not to my knowledge, unfortunately. So I think in those settings, it may behoove the patient to potentially transfer their care either to a federally qualified health center like Philadelphia Fight or an organization like Mazzoni, or to the health department where their labs would be fully covered or free or at no cost to the patient if that were really an issue.
Okay, thank you. This question's for you, Dr. Koenig. One of our attendees shares that she's currently working at a health facility where they order complete metabolic panel every six months. Is this overkill?
Another great question. So complete metabolic panel has all of your electrolytes, your kidney tests, and also your liver tests. And so as we discussed earlier, there's really no reason to worry about the liver when you're on PrEP. And so you don't need a comprehensive or complete metabolic panel. You only need really a marker of your kidney function, but we usually get a basic metabolic panel or a BMP, which really is just restricted to your kidney function and your electrolytes. Again, when we ask about sort of how frequently to check that, those current guidelines are to check at baseline, at 3 months after starting, and then every 6 months thereafter, as the question asker had mentioned. There is a possibility that these recommendations also may change down the line because we are seeing so few problems with the kidneys. So it may be that actually less frequent monitoring may become guideline recommended with respect to the kidneys, but we're not sure. But certainly we don't need the liver function testing every 6 months or probably at all, unless there's another reason, like the person drinks a lot of alcohol or you're worried about hepatitis B or something else. But just for PrEP, there's no need to do that.
Okay. The next question is, in the iPrEP trial, what was the efficacy rate? This individual was just wondering, as they thought that it takes 7 days for infectious levels to show up rectally.
Great question. Excellent question. Somebody is listening really closely. So the efficacy of on-demand PrEP was about 86%. So very effective medication. While it's never been directly compared to daily PrEP, the numbers look really pretty close to the efficacy of daily PrEP. You're checking me on that. So no, that's good. And so I think it's 86%. I'd have to double check. And that held true, and I'll get back to your specific question because it's a great one in a moment, but I want to make a point. That held true even when we looked at people who are having sex either very frequently, and so using a lot of on-demand PrEP, maybe even close to daily dosing, and also with people who are having very infrequent sex. So even if you were only having sex every few weeks or every few months, if you were using the appropriate protocol, so the 2 pills before and then 1 pill and then 1 pill, so 4 pills over 3 days, that the chance of getting HIV, if you were using on-demand PrEP appropriately, even if you were having sex much less frequently, was also zero, essentially zero. There were no infections in those subjects. So the question is, well, how come if you're telling me that if I want to be protected against HIV in the rectal compartment, I have to take the medication every day for 7 days to be protected, but in the iPrEP trial, they just took 2 pills right before sex and that was enough? Well, that is a great question, and I don't have a perfect answer for you, but to the best of our knowledge, there's something about that double dose load that overcomes the need for people to take 7 daily doses. So if you're just starting PrEP and you're taking it daily, then 7 daily doses is still the recommendation for the rectal compartment. But if, for example, you're seeing somebody and you're starting PrEP and you talk with them and there's a risk that they could be exposed to HIV sort of before those 7 days are up, maybe they're going out that night, You know, at YHEP and at John Bell, we do often consider in those cases double dose loading people to start to take advantage of the pharmacokinetics that we saw in the EPRGate trial, to kind of jumpstart those levels, kick off those levels a little bit higher than if you just started at a daily dose. We don't recommend that people sort of take this into their own hands and sort of double dose, you know, on a frequent basis, but certainly at the beginning of treatment, if you kind of, again, want to get ahead of those levels and speed up that 7 days, we do have some data through EPRGate to suggest that double dose load can help you do that.
Okay. The next question, why aren't heterosexual women diagnosed with chlamydia given the same PrEP consideration as MSM with a chlamydia diagnosis?
I don't want to keep talking here, but the reason is because, again, these guidelines were put out by the USPSTF, the United States Preventive Services Task Force, and this organization, compared to all the other guideline-forming organizations in the United States, really lives and dies by the data. They are incredibly evidence-based and evidence-driven, and are very conservative in their recommendations. And so, for women who have had a chlamydia diagnosis, but not a syphilis or gonorrhea diagnosis, there has not been a strong association that shows that there is an increased risk of that population to sort of subsequently acquire HIV. Chlamydia is the most common STI, and is incredibly common amongst women. And that alone doesn't necessarily say that somebody is strongly at an increased risk of HIV, whereas there are stronger data in the MSM population to say even if you've had a chlamydia infection, that your risk of HIV is higher than if you didn't have any STI at all. I hope that answers that question.
Okay, thank you. You have 2 more questions. Regarding myth number 9, providers have a grade A recommendation to provide PrEP, but they continue to avoid the sex talk. Many providers are even telling patients, quote, "You are not at high risk and there is no need for it," end quote. Would you think that moving towards a CDC mandate towards providing sexual counseling to patients is necessary to provide PrEP to more people, or increasing access really needed?
I think the question, it seems like we're a little confused by the question, but I think what the questioner is getting at is, should we be talking more about sex, and how should we not be using the words, you know, you're not at a high enough risk for HIV to be prescribed PrEP? And so I'm not sure if this is the exact question, but it does really bring around an important point. So if a provider talks to a patient and they don't necessarily fit into one of those categories that we mentioned earlier, meaning, you know, they have a partner who's HIV positive, or they've had a recent STD, but by either the patient's assessment, because often, even though we think we're easy to talk to, sometimes our patients aren't going to tell us everything about their sex lives. I don't know that I would tell someone I just met everything about my sex life. And so if someone is asking for PrEP and they don't necessarily fall into one of those categories, I think our role as providers is not to deny them PrEP based on the fact that they don't fit into one of those boxes, but really to maybe have a little bit of our spidey sense triggered to say, this person is probably asking for a reason. Let me do what I would do for any medicine, talk about the risks and the benefits, and if the person wants to start, that we support them around that and just monitor safety as we would for anybody. So I hope that answers the question. I don't know if you want to add to that.
I mean, I think, you know, to piggyback on that, I do believe that if a patient wants to start PrEP, that we should, one, honor that, because I think sometimes a patient may not be as open with their medical provider. And if that's the case, then maybe that patient needs to find a new medical provider, because the medical provider is supposed to be there to answer all these questions and make the patient feel comfortable enough. And so I would say I would err on the side of yes, if this patient wants to, they are asking for a particular reason, and that we should try to probe a little bit more and kind of build some more rapport with them so that they can be more open and honest. I mean, I think the plus side of having retention coordinators or navigators is that they sometimes represent the community or representative of the community. And so they're able to better like get more in depth with some of the risk behaviors that the patient may be experiencing as a way to, I guess, kind of build more trust, right?
Mm-hmm. I agree.
Okay. Another question. What do you think about non-medical companies that offer PrEP prescriptions online? Monitoring labs are performed at home, no need for in-person doctor visits.
I think it's a great idea, as long as you just be careful sort of what company and where your medications are coming from. There are some companies that offer to sort of help you get access to PrEP without ever having to come into contact with a medical practice or a healthcare setting. And I think that's a fabulous opportunity and a way to increase access to people who either have busy lives and can't get in to see providers or really just don't want to have to go sit and wait to see a provider. And I think the more that we can sort of demedicalize or decentralize PrEP, the better.
Okay. And your last question is more specific to adolescents. Are your adolescent patients facing additional challenges in accessing PrEP due to insurance coverage? If so, how is that addressed?
Yeah, it's a good question. That I think the concern is that if an adolescent is on their parents' insurance, there's a lot of concern often from the adolescent, understandably, that they don't want to be doing things like getting prescribed PrEP and doing STD testing if their parents can get sort of a report of this, if they haven't if talking to their parents would potentially be a barrier to accessing PrEP. So for some of our adolescents, parents are wonderful supporters and advocates, but for others, it may be parental support of that person getting on PrEP may not be present, and that could be having to talk to a parent may in some cases be a barrier for a person getting on PrEP who needs it. And so that's a great question, and we're out of time, so I can't get into the details, but the answer to that is that there are ways around that. Depending on the insurance company that the parents have, most insurance companies will actually open sort of a separate account within the parent's account to allow the adolescent or the youth to have their own private sort of sub-account within their parents' insurance that the parents do not have access to. And so we'd be happy to answer questions about that if you would want to give us a call or send us an email if you have specific patients for whom you're concerned about this.
Okay. That concludes the questions. Thank you, Dr. Koenig and Jermel, for, again, your wealth of knowledge around this topic. If those who are still attending, if you have further questions regarding this topic, feel free to email those questions to Cheetah. We can forward them over to the PrEP team for further answers to your questions. In the meantime, please check your emails, as I will be sending everyone out a survey for you to share your experience and thoughts about today's webinar. And you will also receive a certificate of attendance for attending the webinar today. Dr. Koenig, Jermel, do you have any last words before we end today's webinar?
The only thing I would like to do one plug for YHub Health Center is to let everybody know on the webinar that there are options for same day and next day starts for ages 13 to 24. So if you have any patients interested in starting PrEP, to send them over to YHub, and chances are they can be seen same day or at least next day.
Thanks, everybody. It was a pleasure spending this time with you all today, and thank you for your excellent questions and for your interest in PrEP.
Thank you, everyone. Have a great day.
Bye-bye.
Bye-bye.
I am freezing.